Stephanie?
Hi, can you hear me?
Yes.
Okay, Stephanie Haroon, and it says Etzman on my little thing, but I just recently got married. And I am a parent of a young adult who has access services and experiences IDD. And I've been on the board for probably about, I think I joined sometime around the same time Danielle did. So it was during COVID. And a fun fact, so I come from a long line of farmers. And so I also like to garden. But yeah, my garden has really suffered this year. But my tomatoes, actually, I have a Roma plant that is prolific. It won't stop growing them. And then I have an heirloom variety that produced one. So that's it.
Tips you have, I'm all ears.
I think we've gotten did I miss anybody? Kristen. Oh, yeah.
That's
Great.
That sounds actually, negotiating it, took a bite too. Hi, Kristen. Program manager, work with the adult outpatient teams in our 2 hubs. Fun fact.
You like your salad?
To do it.
Yes, thank you.
That's a good fact.
What was it?
Did she like her salad?
Oh.
All eating it. At the same time. I don't know what's so fun about me. I guess I used to run a few restaurants and I worked as a chef, which was really fun. It was very, very fun. So I love food.
She's like a legit chef.
Very interesting.
All right, sounds good. Thanks for taking the time and indulging us on this. It'll just be super quick every time we meet.
Yeah, come up with a new interesting thing about ourselves every time.
Probably.
Okay. Can't go be interesting before the next meeting.
It can't have to be funny or unique. Yeah. Say, I think I've got 3 kids that are blown and grown, or I've got, just something like that, or here's where I grew up, or just something. It's just conversation starter type thing. And so we're gonna move on. We have an agenda. I don't know if you guys all have taken a look at that yet.
Here's
Is there? Okay. And then you sent out the May meeting minutes after it, so I don't know if we've all had a chance to look at it, but this is the time where we need to approve the May meeting minutes. So I'm looking for a motion. Anybody feel so inclined to move to approve the May?
I'll make the motion. I read it.
Okay, thank you. Anybody have a second?
Second.
These seconds, okay. Any discussion, any issues with the minutes that anybody saw? All right, so we'll take a vote, and all those in favor of approving the May 2025 meeting minutes, please say aye. Any opposed? Okay, motion carries and the minutes are approved. So we will move on to the director's report, which is Holly.
Well, I think for my directors, well, I guess I can give a little, I think I skipped over that in my brain because we were gonna do this presentation, but let me think here. There's some stuff going on.
It's this is the time.
Oh, this is the time for this. Oh, okay. Phew. Okay, so Shannon, Amber, and I are actually gonna give a quick update because as you may or may not remember, it's been a few months since everybody's gathered. We were going to be taking one of these meetings to talk about the local plan that's required as part of our county financial assistance agreement contract with Oregon Health Authority. A lot happened since then that shifted some timelines and things. So that's what we're going to talk about today is what's happened, a little bit of history, and then where we're at with the local plan and then kind of what's next. So that's what we're doing today. Feel free to go on to the next slide, Dana. Or I could actually take the thing if it's easier. Okay, there we go. So just as a reminder, the county's agreement with the Oregon Health Authority, the CFAA is what we refer to it as, is our county agreement with Oregon Health Authority to provide all the required services that we do. Just as a side note, we do more than what's required in the CFAA, and we have funding from lots of varied sources outside of the CFAA that allows us to do a robust array of services. But this is talking about this required set of services, often anchored in statute, OARs, just legislative reports that is extensive. It's quite extensive. So we have been negotiating. I have been fortunate or unfortunate, depending look at it, to be on the negotiating team along with about 5 other CMHP directors, community mental health program directors, for the last 2.5 years. trying to renegotiate this contract to actually have it make sense. It is a contract that previously had 30 some odd individual, what we refer to as service elements. And each of those service elements said something like, you need to provide crisis services. And then it had a bazillion requirements within there, lots of reporting. And then the next service element would be something like, you need to provide outpatient services, same thing. And so there's 30 plus of those before, all with their own individual reporting requirements and funding streams, none of which actually made sense because funding over the last 20 plus years has just sort of, there's really not been any rhyme or reason to it. It just hasn't. I can't say it nicely. And the state would agree with me on this. This is not bashing the state. It's really just been like funding came from the legislature for a particular thing. And so then they allocated it out to the counties or some influx of money or shortage of money happened. And then they just or they did an RF request for proposal for different pieces of money. So some counties had a lot of money and some counties didn't fare so well. So it is all over the place. The agreement was about 225 pages. And so the goal of this negotiation team was to streamline this contract, have it make some sense, pare it down, reduce the redundancies and overlap and reporting requirements. And so that's not been an easy feat because this is 20 plus, maybe longer years of convoluted mess that we are trying to unpack and make sense of. And it has big consequences to counties and their systems. But we did it, sort of. So what we did agree to, which I think is a good thing, is we basically pared it down, which I'll get into in a minute, right now we've got it down to 6 core service areas as opposed to 30 plus. We've got the contract down to 88 pages versus the 225 pages. So that's progress. That's a big deal. And I will say you can read it and understand it now. So that's the positive. The goal of this whole negotiation was really to allow us to not have such siloed buckets of money to do tiny pieces of work in the system, but to have a more flexible funding stream to use the money as our local community saw fit, and to focus on these kind of core service areas, and all have it be driven by the local plan. And now the local plan is not actually new. It is something that's been in statute and required for some time. How state interpreted what met the standard for the local plan shifted. We used to be able to use the regional health improvement plan. And some of the efforts that were already in existence in our community, which was lovely. Now we no longer get to do that. We are now required as the CMHP to develop our own local plan, but it can and should be aligned with the RAW and the RIP, and it should include stakeholders in the development of it. So Shannon and Amber primarily right now have been doing a lot of work on developing our local plan, and we did pull from the thousands of other local plans that we're asked to do, the RAW, the RIP, and a CCBHC needs assessment that we just had to do back in summer that was quite robust itself. So it wasn't like reinventing the wheel, but it was a different document. So,
One question.
Yeah.
So those program elements evolved over time. Was it kind of like a legislative package got funded or whatever, and then they just create a new program element? And then going back 5 years, there's program elements that were still there.
Yeah.
So that
sometimes it was because of a legislative, request or some phenomenon that was happening in the community at the time or the state at the time. But some of it's just around evidence-based practices, best practices around like children's services. And now wraparound should be a thing we do, and PCIT, and just all these different, specialized ESA as another example, school-based health centers. So all of these things over the last 20 plus years just evolved, and then they got added and
yeah,
added.
so I'm just thinking they kept adding program elements.
Yeah.
Funding this one, but not funding what they did a couple years ago, but they're all still in the document.
So then everything got underfunded essentially.
Yeah.
And so that's ultimately what the CFAA was. It was a lot of underfunded mandates. And this was a way for us to pool the money together to say, how do we want to fund our system? But there's some caveats to that.
Well, then I just think from my point of view, we'd see what did the legislature just do? And then where the money, and then every couple months, we'd see an update because there's gonna be more money distributed for a program element. So every time we think we're done, another version of something comes out. So we see that at the board meeting all the time.
You do all the time, and I don't know how, this is gonna be an interesting part of CFAA, because we have these core service areas, but then you do get the legislature that says, okay, Measure 110 is an example. You know, although that wasn't necessarily in the CFAA, but aid and assist is a really good example. So those, for you, just as a reminder, people who are severely mentally ill, that commit crimes, that can't aid and assist in their own defense, end up in this system, what we refer to as 370 or aid and assist. That population has skyrocketed over the years. So and the state Oregon Health Authority is actually under contempt for not meeting statutory guidelines around how quickly they're managing that population. So what happens as a result of that? Legislature addresses it, invests, I think we got, I can't remember how many millions were invested this year. That's going to be coming into the CFA with additional requirements that we now have to do. So even though we've created this sort of more flexible thing, it will be interesting to see how that jives with legislative intent and specific funding that comes for specific projects and.
Also, is this the document that had the clause in it says, depending on funding, and then they were trying to say, no, not depending on
And
funding?
I'm gonna talk about that.
Okay, good. Got it, coming.
Yep, it's coming, because that is, yeah. So that's just kind of why we were negotiating, why we've been doing this work and what the goal and the intent was. So we can go to the next slide. All right, so the core service areas, just quickly, the Association of Oregon Community Mental Health Programs, which is the association that leads and is very effective and organized. They helped draft these core service areas, and OHA actually listened to us on this and agreed with them. So basically got lumped into a couple of these 6 main ones, which is system coordination and management, which is essentially all the things we do that we don't really get paid for, meetings and coordination efforts, and just, you know, everything that comes with sort of running a CMHP. We've got behavioral health promotion and prevention, which for the CMHP here, we actually pass through dollars to our public health department because they have such a robust promotion and prevention program that it wouldn't make a lot of sense for us to try to duplicate that in behavioral health. So we work very closely with public health on that front. Crisis services is its own core service area, and that includes anything from mobile crisis, you know, to stabilization centers, to everything, to the youth services in there. And we've got an involuntary and forensic services. So that's the aid and assist that I was just referring to. That is the Psychiatric Security Review Board, which is the guilty except for insanity folks that commit major crimes and are charged. And that civil commitment is in there as well. I think that's it. Oh, and jail diversion. And then outpatient and wraparound services. So wraparound, I don't want you to get confused with wrap. It's all the wraparound services. It's case management, it's peer support, it's everything that we do to support an individual in treatment. So including wrap.
It
It
includes that wrap,
includes
but
wrap.
it's not.
It's not just wrap.
Little W wraparound.
Little W wraparound.
Or the.
Exactly.
Ah.
The W wrap is in there.
It's actually not in there. It's not funded.
Oh,
So-
right.
So that is not, it's one of the
It's not
services
in
we
there.
provide that doesn't come through the CFAA at all.
Comes through the CCO.
It comes through the CCO and insurance reimbursement.
Yeah,
So
thank you for reminding me of that, yeah. So this is wrap around everything else besides wrap. And just our general outpatient services. So a lot of the programs Kristen oversees.
there's
Just
mine,
our-
right? Makes sense.
Our traditional, like somebody comes in for therapy, gets outpatient services, that population. And then residential and housing services. And I don't love that they use the word housing in here because we don't really get money for housing. We have a homeless outreach team, but we don't get funded for that through the CFAA. But there are like our adult foster homes, they kind of lump into things like, kind of refer that into housing. But it's primarily our residential services in there. And then there was a couple places in which, so what we learned through this process was that all the 30 plus service elements that we used to have were all funded through state general fund, which meant that it didn't have to go to a specific thing. We didn't know that all these years. We thought the money required to be spent on ESA, it required to be spent on ACT, but it turns out it was all general fund. And there's actually a lot of flexibility when it comes to general fund and how you apply it. So what the state is going to do is give us our bucket of money that we've gotten from all the 30 service elements, and we decide based on our local plan how much we put into those different 6 core service areas. It's great. It's great in theory. We'll talk to you about the problems that have arisen because no good deed goes unpunished, right? Like this is, so yes, in theory, this is wonderful because in Deschutes, it may be that we actually have more of a need for crisis services or, you know, involuntary than we do for outpatient or vice versa. Like you, we have flexibility and it can change year to year based on what's happening in your community. So you can move it around. All good stuff. There was a couple of buckets of money that we've gotten through the CFAA that were not flexible. So block grant dollars come from the federal government. They are very specific on what they have to be spent on. So those are carved out in a separate area. And we have to apply them per the requirements. And then there's some services that we actually invoice the state for that we get reimbursed for, and that's a separate bucket of money. So that's just not much getting the weeds on there, just for note. Next slide. Okay, so if you remember, we had originally hoped to have this new beautiful contract that we had been working on signed by July 1 and have the agreement in place. And we were to have I think our final, was our draft local plan due by July 1. And so we had planned to do some work with you all to have that plan come, I think in June. And then things kind of started to implode. And this gets to Commissioner DeBone's point. Negotiations got kind of stalled because OHA did something that was a bit surprising to us along the way. In that there had been a clause in our contracts all along, and it also happens to be in statute that says a key phrase, subject to the availability of funds, the county, the local mental health authority shall do the following things, and then lists all the bazillion things that we're required to do. OHA took out subject to availability of funds language in the contract. And they had tried to do this 2 years ago. We fought them on it, threatened not to sign, and then they put it back in. So they already knew this was a massive sticking point for us. But they did it again this go around, and they did it specific. They didn't do it for the whole contract. They did it for what they're referring to as the priority population. So they said they took out subject to availability of funds for crisis services, civil commitment, that guilty except for insanities or any of our forensic populations. The problem with that is that these are our most complicated, most underfunded, and most increasing volume of services that we are seeing. So that's, if you were ever going to have subject to availability of funds, you would want it in that bucket over the other ones.
So there's 36 counties in the state of Oregon, Association of Counties, the Board of Commissioners for each one of the counties, 36 counties, plus all the health departments. And we got the call, it's like, hey, this is #1 flashing red priority across the state. Make sure that each commissioner understands what's going on. This is where we need to stand together as counties, because having that clause in there could turn, and Deschutes County is always in an interesting spot because we're generally financially healthy. I mean, we don't have extra money, but we're funded better than a lot of counties. It could turn some counties upside down with these requirements. So we got the call across all counties. Hey, everybody, pay attention. This is serious business.
Yes, and they did, and they were effective. And so kind of stalled our negotiation. Association of Oregon Counties got involved, commissioners, like you said, everybody under the sun that was part of this conversation. We actually got a meeting with the governor herself. I was on that meeting. And it was clear to us that there was not going to be any movement on that issue. So it looked like it was about to implode. Hence why I have the explosion emoji. It was really close to counties not signing the contracts, which, you think, okay, well, what happens if a county doesn't sign the contract? Well, it's massive. There's massive implications if a county doesn't sign the contract. You don't get the funding from the CFAA. So therefore, and we don't have a lot of other funding. So, I mean, you're talking upending the behavioral health system in your community. So not a decision anybody wants to take lightly. Thankfully, at the 11th hour, it was decided, let's extend the current CFAA for another 6 months, and let's continue negotiating. So that at least gave everybody a sigh of relief, because this is in the middle of summer. Everybody's gone anyway, and it was hard to, it was very stressful. But yeah.
So just a foundational thought, and whenever Association of Oregon Counties gets together, remember there's all the other elected officials, the assessor, the treasurer, the clerk, DA, sheriff's office, even the road department, everything. Watch out for unfunded mandates, because the state legislature can come into a session and say, we have a great idea. How about we tell counties that they have to do this and fund it by 50% and they'll make up the difference. And it's easy for the legislature to come to that conclusion, but it's a disaster locally. As I say, Deschutes County is a little bit more resilient financially, but we're not even in the middle of the pack. We're probably ahead of the top third that can handle it. So that means 2/3 of the counties will go upside down if we're not careful with this. So we're always watching out for unfunded mandates. You're required to do this, and we're not going to give you enough money to do it. So this happens all over the place.
There's a bazillion examples of where we're not funded and we have mandates.
Yeah.
And politically, are the counties pretty much aligned?
Well, so yeah, there's about 120 commissioners, 36 counties, and that is the Association of Oregon Counties. That's my point. It's not just health. It could happen in all kinds of areas, which means they're pre-spending our general fund before we even have a say. And it's just,
Is there any division within the,
oh no, there's not.
About this topic,
about this?
No, it's just kind of a natural, we have the budget authority, or like you're elected county commissioner, you have the budget authority, except the state legislature tells you how to do it. It's like, well, let's not do that. So it was something you always have to watch out.
well, and I will say there was consensus among all the community mental health programs across the state and the Association of Oregon Counties that we wanted this language back in. There was not necessarily consensus about who was gonna sign and who was not gonna sign, and that can't be done collectively. It needs to be done on an county, you're a lawyer, all the reasons why you can't do that kind of thing. So the problem with this specific language being tied particularly to that population is that, like Commissioner DeBonne said, though, we were okay, actually. Our civil commitment numbers, our aid and assist numbers, we're actually doing a pretty good job in terms of how we're managing that population. Multnomah County, Washington County, Clackamas County, their numbers are skyrocketing so high in those areas that if that was taken out, what it was going to require them to do, and ultimately us, if we ended up in that situation, is move all your funds from your outpatient, from any prevention, from your crisis service, or to all, and move it into these priority populations. And therefore you're funding only the most extreme services and you're not doing any upstream work, which for any common sense person, you realize that will only make the problem worse, not actually do anything about it. So that was kind of our argument of like, why would we just continue to enable this problem? Like, let us do the proactive stuff. But it was all really tied to this contempt lawsuit that is at the state level.
So it was kind of passing the buck.
Yeah, a total 100% passing the buck.
This,
Yes.
we need to do it, so we're passing it.
Exactly. It was 100%. I mean, and I still will say that to their face, and I believe that is what's happening. They're being held in the courts. They're passing it down to us, and that's kind of what's happening. So what we agreed to do, we extended the contract for 6 months. This is a bit of a time of trust building that's happening during this next 6 months. So one thing in the previous iteration was that we were going to sign a 6-year agreement. This was supposed to be a 6-year agreement too, and then do the local plan, and then find out if it's approved and see what our budget is. And so to sign before having done our local plan and seeing how the state was going to let us allocate our money wasn't something anybody felt comfortable with. So now with the extension of the timeline, we're doing the local plan first. So here's where the trust building comes in. We're going to design our system the way we think that it needs to be designed. We're going to still prioritize prevention, outpatient, still going to meet the needs of our acute population and priority populations. And we're going to submit that plan to the state, and we have to have that done by October 1st. So our hope is to submit the draft by October 1st, and then come get some feedback from OHA, bring that draft back to you all where we can spend some time on the plan, and then have a final draft submitted by December. And then the new contract will be signed in January. So if it goes the way OHA has sort of promised us and indicated that it will go, is that nothing will change for us. We will actually have a good, robust system that we can all feel good about. That's my hope. And we'll know that before actually putting pen to paper on a contract.
And the money will be guaranteed then? Is it?
As guaranteed as anything can be in these times. Yes, it's a contract with the state. We'll get our bucket of money. We will be able to allocate it per our local plan. And we will know that before signing a contract. I also don't think it's going to be a 6-year contract anymore. It's more likely going to be a 2-year contract, which I actually feel better about knowing. No, because I don't know if we'll win the battle around subject to availability funds. I just don't know. If we do, great. But we may not.
Yeah, there might be a couple people that have hands up or comments. I just wanna make sure we.
Hard to, and this is dense information, so I apologize, but
No, it's
you know,
good information.
So is there anyone? I generally watch it on my screen too.
Okay, perfect.
I don't see, just wanna make sure.
But we had a lot of other like technical requests in the contract of language change, but those weren't the biggies. It really was the subject to availability of funds, and it really was the prioritizing of aid and assist, PSRB and civil over everything else that we were sort of pushing back on. So we'll continue to negotiate, see where things land, but that's kind of the lay of the land as we see it right now. Next slide. I think I covered all this. Yep. Yeah, so, I mean, there's still this possibility, you know, at a state level. And our county will have to make its own individual decision. It's like, see how these local plans work out. There may be counties that submit a local plan and they're not approved and they may not sign a contract. And so I really hope, given the challenges that we're gonna be facing ahead already with Medicaid cuts in the next year or two, that we don't also have this on top of that, because it's just unimaginable. So because it's so unimaginable to me, I'm hopeful that we are gonna all find a way to collectively come together and forge a way through.
It's kind of a paradox to me that they're asking us to come up with a local plan, which has to do with local authority based on, you know, what we know our community needs. But that's held up against
Yeah.
potentially having to say, nope, gotta give up the program because we can't go with the contract language. And then what? Then what? Either a private entity has to raise their hand and say, well, we can take over this community's.
Then the state's gonna have to pay that.
Or,
Well, and that's what the state said.
and that goes
And it's
away
gonna be
from.
way more expensive.
Yeah, well, the state kind of, I guess, early on I don't know if I use the word threat, probably shouldn't use that word, but suggested, was. Something might do, was if the CMHPs don't sign, that they would be in fact looking to see what other providers are out there in your community that would be willing to become a CMHP. And we as CMHPs collectively laughed because, I mean, there is just, we know how this, I love the private practice clinicians and practices in our community. They serve an important purpose for lower acuity populations. There is no one raising their hand to serve aid and assist, civil commitment, PSRB, crisis. We cannot have, no one does those and no one wants to do those. So it's just, it's not what you go to school for. It's a CMHP responsibility. So the odds that the state would actually find anybody to be able to do this, and also keeping language like you have to do this whether we pay you fully for it or not. Who's it never? So
They would violate their contempt order probably too.
yeah. So
If they find anybody, then they're just.
So there was a lot of posturing, but I think hopefully that's mostly what it is, and we'll get through it, and these local plans will help ease people's minds. Yeah, we can go to the next slide, because I think.
So Holly, would it help when you guys are back in those negotiations for our board to do a letter that says this is imperative for our community, that this funding is, not, that it's not required that these priority populations, that it all goes to this? Would there be?
Nothing ever hurts. I don't know if it
What
would.
did you think about it?
Yeah, let me see where things go.
It's talked about here.
Where it could be helpful is if we get back to the governor, like if it comes to the governor's level again, which I hope it doesn't, but if it does, we've got the backing of AOC, which is a pretty powerful group, but if there are then also letters going directly to the governor's office that are advocating for something different, that I think then that could be a really good use of this board's efforts. So let's hope it doesn't get there, but if it does, yes. So I'm gonna turn it over to Shannon and Amber, and they're gonna talk about the actual local plan, the structure of it, and then sort of where we're at with it and next steps. You want me to take this one?
Sure, yeah. So this is the actual plan that we're working on, that Shannon and I and others are contributing to, has some key components that's required. So this is what we'll be submitting a draft of here in a couple weeks, and we'll review with you all after we get our feedback from OHA. So we have to describe our current continuum of behavioral health care, our organizational structure and key partnerships. Describe the core service areas. Those were the ones Holly reviewed with you a little bit ago. We have to address how we'll use the money to fund services for the priority population. So again, those are ADSIS, PSRB, crisis, etc. And then this is where depending on availability of funds, we'll identify how we're going to use funding to support other services. Again, those outpatient services that we've been talking about. We have to identify any unmet needs and gaps in our critical services. So after we've described everything we are doing and are going to do with the funds, we have to also identify where are the gaps, and we know there still are gaps out there. And then we have to identify a plan for addressing those gaps and include applicable metrics that will be required to track, some of which we're required to, and then we might add some additional metrics that we feel are really critical for us to track as far as outcomes and trying to move the dial on certain things. And then we submit a very robust budget template. Thank goodness for Cheryl Smallman, our business officer. It is cool. That's a doozy of a document. It is. And then a budget narrative as well. So this is all what's going into this local plan that we'll be eventually submitting.
And a side note on the budget template, I mean, we fought hard to not have it be the way it is, and we lost, unfortunately. It seems to be a bit of a theme, but what they're saying, their goal and having, it's more detailed than it's ever been. And it's not just related to the dollars that the CFAA is funding. It's more. It wants to know every dollar that we had. And so, at a level of detail that I've never seen any budget template ask for, and down to the, individual staff, like it's very detailed. So, and so what they're saying, their hope is that to be able to demonstrate where the gaps in funding from the CFAA are so that they can advocate at the legislative level for funding. So we'll see if that actually at the level, we'll have more information than we've ever had around the budget, which is probably a good thing, but boy, I feel bad for Cheryl Smallman.
And we have we're a growing area, so we have more legislative connections here. Eastern Oregon senators, local Central Oregon senators, Republicans, Democrats. So I mean, we're in a good spot when it comes to the legislature now. Obviously, the population in Portland Metro is always the big boy, but we're getting there. Just with the number of people that can be in the legislature advocating for the reasonable work we're doing.
Right, next slide, Deanna, please.
Sure. So Holly mentioned we use the RIP, we use the RAW, we use our CCBHC assessments. We try not to recreate the wheel. We get barriers from our community. So to identify our unmet needs and critical gaps, we know we have them for civil commitment resources, aid and assist and PSRB resources. Our hospital residential, we do highlight that as a need, but we also note that we did the groundbreaking for the adults and that youth is coming. And that we are adding AFH capacity. Permanent housing, supporting housing, a huge need in our area. Medical transportation, particularly non-emergency medical transportation and outreach to our rural areas, coming into appointments, very limited, Monday through Friday, 8 to 5, is not meeting the needs. We have unmet needs in terms of our youth and older adults. In particular, our older adults in our geriatric services, substance use, and increased demand for language access and translation. Those are not some of those needs and gaps in there are covered in the CFAA, and others are not. In particular, like we mentioned, wraparound. There is no funding carved out that says, hey, this is one of your areas. So. We're going to have a couple slides at the end where we're going to ask you guys for your input on this too, to make sure that we're not missing any.
And just one thing on the civil commitment aid and assist resources, it's amazing that we're doing, we are leading the state in our aid and assist approach. We're one of the 5 pilots in the state that are doing some really great work in keeping folks out of the state hospital and actually being able to treat them locally. But the numbers are increasing well over 100%, since like 2021 or something like that. And civil commitment has increased. I think it was like, what did I put in the thing? 153% since 2015. And so our numbers are, we have 2 civil commitment investigators that have to cover the entire spectrum of both monitoring and investigations, and that has increased 153% with no additional resources. So that's really where, when we talk about unmet needs, we need more money in those areas. And it may mean that we do pull for money within our budget, and now that we have more flexibility to make sure those services are shored up the way they need to be.
Question.
Yes.
Excuse me if
Oh,
I
no.
missed it. The aid and assist, the contempt payments.
Yes.
Where do those go and what happens at the local level?
Yeah, that's a
With those
great
money.
question. They go to DRO, Disability Rights Oregon, because they're the people who sued the state. And so the contempt money is going back to DRO. DRO has said that they want to work with community mental health programs around how to reinvest those dollars to actually start to solve the problem. And it's like, and that could mean, but the problem is we don't always agree on what the best approach to solve the problem is. So in our view, if we had more secure residential treatment facilities, we wouldn't have to send people to the state hospital. We could keep people locally. DRO is generally not a fan of secure facilities. They generally want people in a community setting, non-restrictive. And I agree, that's really generally where we want people to get to. They just can't always start there. And so we'll have to work that out, but that's what they're saying. They're saying it's gonna come back to communities, but we haven't seen any of it. Wanna take this one?
Sure, why not?
Yeah, so I mean, a lot of our plans to address gaps are, continuing to advocate and continue to invest in these programs we've already been talking about. So, I mean, these are things we haven't been doing already and aren't already seeing some improvements around, again, groundbreaking for the SRTF, and we're still in negotiations around an adult foster home. Opening one in Redmond.
Open one for sure.
And health, another one hopefully in bed for adults. We're continuing to pursue options with permanent supported housing and other alternative housing places, expanding the mobile outreach and crisis walk-in services in rural areas wherever possible, increasing our school-based behavioral health capacity and our therapeutic resources, again, focusing on youth needs. And again, calling out IDD mental health co-occurring concerns as well. So again, not that we aren't doing these things, we're doing them. We're just want to continue to invest and advocate and get the financial support we need to expand.
And the crisis services in rural areas, that's something we've been wanting to. In fact, our Kingwood location in Redmond, new building, we actually built it out to be able to do crisis walk-in in there. We just don't have the money to put staff in there. I mean, the states our crisis services are so underfunded in general that to expand them at this point, it's just not feasible. So that's an area that I know Redmond would want. So they don't have, the stabilization is great for a lot of things, but when you gotta drive, and that's not always ideal for folks,
So when you talk about like plans to address the gaps in this local plan, you're putting in specifics to all of these, and that's something we'll get to see after it goes to the state, before it goes to the
Yeah, we
state?
decided not to bring you the pre-draft because I hate for us to do a bunch of work and and then them come back and undo it all, and then we have to come back to the drawing board. I think we'd rather submit what we have, make sure that they're comfortable with that. And then anything that we do is gonna be additive. So at least we know we've met the minimums of what the local plan is gonna require. And then we can add on specifics of things that you all wanna see or ideas you have for how to enhance it. That, we thought that, I talked to Melinda and like just felt like that'd be the best use of
No,
time.
that makes sense. I mean, that you're saying that it's to meet the minimums, and
Yes.
then we can talk about.
Totally
what-
enhanced, yeah.
Obviously,
Always being really kind. We sat in lots of local planning meetings and had, people ask questions throughout the state, and it wasn't a lot of clear guidance. It was kind of like, oh, well, it's up to you, but we want this. And so because the guidance was not so clear, it just felt better to yeah.
We're not really sure if we're even doing it right to begin with, because the state has been really wishy-washy on like what we're supposed to submit.
Yes, one more specific.
yeah, I mean, because I know personally on the IDD mental health and youth and that combination, and especially when we look at DRO holding these funds, it also, it's been my soapbox. We start young and early and often in outreach, and people know it's available,
Is there any role for us with DRO as they
Yeah.
consider reinvesting the money back in? So keep us in mind.
I will,
for that.
yeah. I think that they have just, right now, it's been initial conversations. I don't even know how much money they've received yet. I know it's $500 a day per person that did not meet the requirements. I would imagine the state has found a way to get better at meeting the requirements, knowing they're spending that much money. But we haven't seen any numbers yet, but Dr. Pinels, who is the expert witness, neutral part of the state, is basically informing all of this work. So Dr. Pinels is working directly with DRO and Mayo CMHP. And if we get to a point where there's recommendations or advocacy that can be done, I will absolutely loop you all in.
Got a few more gaps that we're still working on. We invest now in our bilingual staff. We have stipends and we have levels, and so continuing to do that. We talked about supporting the psychiatric residential facility for youth in Redmond. It's very exciting. Strengthening our older adults care coordination and training behavioral health specialists for the geriatric population. Really looking at how we expand detox capacity, and that is, is something that we're always after, and then our SUD residential, and then continue to advocate for improved transportation resources. I sat on the state's non-emergency medical transportation work group for the last year with the state. It's complicated, and so really it's going to take more than a year of sitting on that to undo some of that.
On the non-emergency transport side, are you aware of any concerns specific to ModivCare? I had an individual doing ride reimbursement being told they can't reimburse them because they're bankrupt.
I have heard that rumor. I have not seen anything confirmed. So that came to me as a rumor yesterday.
Same, yeah.
But I have not seen any facts to that yet. Yeah.
Okay, yeah, no, our folks are still showing up and all that with their rides, but I heard that and was very surprised. I heard that Monday or Tuesday.
So my message to the clinicians was, let's make sure that we're not like kind of going with that until we get formal notice, because there will be a formal process for that. And then if we are not getting rides to continue to do the grievance forms through Pacific Source, that's really, really important, because then there is, and I hope we made some headway. There's going to be some changes that have accountability from OHA to the CCOs when those grievances are coming through. So that was probably my loud voice. That was a little hoarse on that one, but like just to say, hey, if we have grievances, what are we doing with them, right? So I'm going to say hang tight, because I haven't seen anything official.
No, I was just like, oh, I'm gonna file that for later when they told me that. But I can say that the clients who have voiced grievances since we brought this up in here last year as an item are saying that it is a little easier. So whatever has been going on, there's some positive. So thanks for working on that.
Good to know.
Yeah.
Could you explain that? I mean, I understand something about transportation, but tell me about this.
There is is basically the brokerage that sets up a ride. So like calling Uber, ModivCare does the OHP rides. And so there's a couple different ways they can set up a ride for an appointment. If you have your own vehicle, you can get reimbursed. If you have someone that can take you, they can get mileage reimbursement. There's some other resources through there. It's a very, for something that should be pretty simple and straightforward, like the procedures are like 14, 15 pages long. And so really working at the state level to say, one, this should be at the 5th and 6th grade reading level. It should be easy to navigate. And there should be alternatives for individuals that have an appointment at 7 a.m. or 6 p.m. at night, whether that's through medical, there's Uber has a medical component. And so really looking at alternatives so that it's not just always through ModivCare.
So then who is ModivCare? Who is that?
ModivCare it's just an organization. They contract with the CCO Pacific Source, who holds the responsibility for making sure that non-emergency medical.
So it's not dial a ride or I mean, they may be an option or something.
No. It's
Making
different.
sure I know who they were.
Yeah.
It's a specialized vendor in the community.
And those complaints with access and transportation were across the board. Mosaic patients were also, we struggled with that immensely and have also heard less negative things, more positive,
The portal
easier.
portal for reimbursement has gotten much easier. And then there were also created videos, so you can get instructions in writing, you can get it verbally, just auditory instructions, and then you can get it by video. So really trying to make sure that there's multiple ways to learn that process as well.
Can I ask one thing about the local plan? Does it also talk about partnerships, community partnerships? Do they ask about that? Okay, I imagine, because you mentioned school-based health center, and you know, and I imagine there are lots of entities, right,
Section
that are.
one, that very first one that Holly talked about, that's not, we don't get funding for.
System coordination and management.
Oh,
So there are,
sorry.
yeah, but as part of the local plan, there is a requirement that it goes through particular groups. Behavioral Health Advisory Board is one of them, the local alcohol and, you know, the thing that you all just became. That's another one, so 2 birds with 1 stone there. And then it also, but they were gracious, I guess is the best word. And allowing us that we had just gone through our raw and our rip. So I was like, are you seriously gonna make us get all those people back together after we just did all this work and rehash all this? And so they said, no, we could use the collaboration that had already happened to, especially since we were using it to inform our plan. So we're really keeping our community partnership involvement in the local plan, at least this year, to a minimum, because we feel like so much has already been done on that front. We'll take it to our board. Well, you know, there's a couple of steps. We're gonna need. LPSC is the other one, Local Public Safety Coordinating Council. So that you'll be very, again, Captain Schultz.
We've been sending somebody to that.
Well, I don't know. I haven't, I don't know, but we're gonna be presenting, I think in November on that.
Yes, thank you.
Same exact presentation.
We just have one more slide, and that is, just as we spoke today, what additional gaps should we include? Or ideas do you have around addressing these gaps? And I know you're on the spot here today.
You'll have another opportunity.
You're gonna have another opportunity, but if there's something between now and October 1st that you would like us to include that we didn't cover, please let us know.
Is that for now? Are we gonna talk about that at all?
Do it now, or you can.
You got ideas right now,
Or
or
you
throw them
can-
out there.
I will say that we're getting close to 1 o'clock. It's 12:56 and our meeting is supposed to end at 1. I think this is a fascinating conversation and I'm perfectly willing to extend the meeting end time. But I just want to be mindful of that.
And I do have to leave by like 1:10.
Can you just go back to the gap slide and I'll just take a picture to mull that over? Thank you.
Yeah, and we can send this presentation out.
It's out to you.
Oh, that'd be great.
Yeah.
I'll be more likely to look at it.
Right.
I'll look at my
Yes,
picture.
feel free to attach
There's
to me
one more.
if you want. Will you go back one more? There's 2 sides, 2 sides.
Thank you, yeah.
Try to include big ones that we, you know, that are obvious, but yeah, there's others or areas for things that you think we need to do better at. We're all ears. And if you have suggestions for how we might get there, even better. Because it's hard when you just get problems without actually some ideas for the solutions.
Thanks for your hard work on all this, you guys. This is like, feels like beating your head against the wall a lot. It's pretty frustrating process.
Yeah, it was a little frustrating to have to do yet another plan. But, you know, if it gets us to a signed contract that we can all agree on and we can keep doing services, that's a good thing.
So just permanent supportive housing, you know, we've got Cleveland Commons up there. We've got people coming to us at our board meetings, or one gentleman, and sounds like we need to figure out as a community and a society, what is this thing? Because people want to be there, but it's also a soap opera and it's low barrier, so it's very complicated. So I'm not judging in any way, but let's not just put, oh yeah, permanent supportive housing is gonna fix things, because it is wild over there is my understanding. So just
I think permanent supportive housing certainly comes with challenges,
Yeah.
there's no doubt. But I think the model that we have been proposing or looking into is a much smaller version of Cleveland Commons in a smaller community like Lapine, managed by the community mental health program. And all 3 of those things are vastly different than how Cleveland Commons is currently operating. Not
so it's a
saying
learning
anything
curve.
about
Yeah, as I say, I'm not even
Cleveland
saying
stuff.
that either. It's just a learning curve.
Yeah.
You know, it sounds like, oh, well, let's just go do this. It'll be great.
I mean,
Not
and it says
complicated.
for supportive housing and other alternatives. So I think that's the key. Like, there's probably a place for certain clientele that's the right fit. And then what are those other options? Yeah.
Some people, that is not the right fit. Absolutely. See more structured housing options. Yeah, agree. Any other questions or?
Good discussion. I feel like I learned a ton. All right, so if it's all right with you guys, I'm gonna move on to the next agenda item, which is pretty quick, and Kristen and Amber, it's on the drug and alcohol planning committee. Do you have any updates? You don't have to spend a lot of time on it, but I just want to on a monthly basis, have a spot for you to report on anything that we should know about.
Any updates? That's what we're, it's like, this was a long time ago we talked about this.
Anything related to substance use, treatment and the collaboration that you're a part of with that larger group, if there's anything new or that you're working on, you can give a quick Cosmos.
Junior. That's why I wasn't sure if that's what.
Yeah.
Yeah. So we started a pilot earlier this year on the AOP outpatient, adult outpatient team. Small pilot for treating folks at a 2.1 level of care for substance use, which is as a intensive outpatient level of care. And these are folks that have co-occurring mental health and substance use. So there's not another program like this in our area that treats both happily. So we've started that. We were up and going and gathering data on and learning as we go along and adjusting. Our youth program is in the early stages of starting that development and planning to have something up and rolling after the first of the year.
Did you say that's me?
That's huge.
Oh, you said that's me. I'm like, yeah.
So currently this pilot is really just serving folks on the adult outpatient team. The larger vision is to be able to kind of expand out to the hubs and to have any program within our behavioral health department, serve people who are needing that level of care. So we're learning a lot as we are going along. I had to have some data to look at more intensively here in the next month or two. To have
That's great to bring to this meeting.
Yeah, I think we're really like, this is a huge learning curve. Yeah.
Yeah.
So we just have a couple, it's a very small team doing this work, but so far it's been really amazing. We have some really good outcomes and some very wonderful stories that we could share.
And this was a CCBHC requirement that we had to either do 2.1 level of care, and Lee knows all about this kind of stuff, I'm sure, but it's the intensive outpatient, or we had to contract with somebody in a formal capacity to do it, and spent a lot of time weighing those options out, and really it was decided that we really felt like we needed to do it in-house, and we wanted to, meet this need, serve them, not have to send them out to get this level of care.
Yeah, we also took this question to the SED forum that we meet with every month. And we asked our community partners what they thought the need was and if they wanted to see the county take this on. And we got a unanimous yes, please. There are programs that do this level of care, but for folks that are just substance use, they don't combine the mental health component. So there's a gap in our community. So we decided that would be, we have the support to do that.
Big lift though.
Yeah. It's been great so far. Like I said, we're continuing to learn and figure out how to do this really well. So.
Thanks for all your work on that, Kristen. You've really spearheaded that effort. And like I said, it was a really big lift, and I think it's going to really produce some much better outcomes for the people that we serve and allow us to do it in-house and not have multiple providers intervening in their care and making it complicated for them.
So next up on the agenda is a community or the outreach committee report. Julie McFarlane couldn't be here today, and just as an announcement, she's planning a move to Salem. So we're going to lose Julie in addition to Dr. Bohm. You all probably saw that email, and so we need to start thinking about who we know that might be a good fit for this group, and we'll probably have to do that soon to get our numbers to where we're supposed to have under the bylaws. So we're gonna pass that, unless Cameron, I think you guys went to visit the jail. Is there anything you want to share about that this summer?
That was a great experience. It feels like a long time ago. But I want to say one thing about outreach is that we are specifically looking for folks with lived experience. And so I think that would be if talking to people you know or getting the word out in your different circles. We all know somebody who's had some sort of experience or a family member. So I think that's what we're looking for particularly.
How many are we looking for at this point? I mean, I know that makes two that we're talking about, but were we also looking for at least one more before that?
I think we were. I haven't gone back to do the count and figure out, but I'll work with Cameron.
Yeah, I haven't looked at that.
Because she's
I think we're at 3, but I think at least 2 with lived experience.
Yeah, to keep our.
Don't quote me on that.
50%.
We had 51%.
Yeah, So. And then we'll move on to the chair's report real quickly, and then I'm going to cede some time to Captain Schultz to give us an update on what's going on with the sheriff's department. Lee and I are doing some work with the Public Health Advisory Board. We met with Thomas Kuhn, Tom Kuhn, to kind of figure out how they function, because they're sort of our counterpart on the different side of that. And it feels like it's a learning opportunity for us, because I think they're a pretty well-developed board. And so we want to see how they function and see if there's anything that we can bring back to this board to make us function better. And so we had a really good conversation this week with Tom and have some kind of exciting ideas. I think what we may take, the direction we may take this year is, as he called it, a housekeeping year, to try and kind of change how we function, change how we operate, and what our priorities are. We've already been talking a little bit about these strategic priorities and stuff. And so we may end up having a retreat, which won't be super long. It's not like an all day someplace, but we may follow in their footsteps on a couple of the ideas that we learned. So that was really good. And then I would like to ask Captain Schultz to kind of give us a brief update about what's going on in the Sheriff's Department.
And I'll be real brief, 2 minutes. So we do have a new sheriff after I would say chaos that we had.
Soap opera.
And Commissioner DeBone was a big part of that. So the sheriff that we have in place now was appointed by the commissioners and will serve in that office until the general election in a year and a half or a year. It changes the course of our election cycle. Instead of every presidential election cycle, that's where normally we picked our sheriff. But because of this person left earlier, he will run in the next general election cycle. And so everything's going pretty well. As you can see on the chart, it's very difficult to see. Ty Rupert is the sheriff. Aaron Wells is the undersheriff, but he's looking at leaving. He came in with the other sheriff, and he's in a process with another agency to move towards. The sheriff is actually going to be keeping 3 captains. I'll be one of them. And we'll be dividing duties as that comes through. But we're gonna right now the election, I think it's open to run for sheriff. So if you're interested in being sheriff, I can help.
Or commissioner, I mean, they're wide open now.
So, and it closes in October.
Our health services director.
Next March.
March.
So it's a window up until March, and then it's a May election for the primary and the general. Yeah.
So are you, when the undersheriff leaves, or will that also be replaced?
I think what we'll do is close that, because we're looking at money, because the money's
So
saved.
close it.
Yeah.
Sheriff before, did we?
We did not have one.
I was gonna say, I don't even remember that. Over the years.
So Aaron's been.
Yeah, Deschutes County has not operated with an undersheriff for a long time. Normally do that when you're leaving and you like the person that you want to win, you put them in that spot. But many sheriff's agencies around the state doesn't have it, but they may have chief deputies. That's what I was in Multnomah County, the chief deputy. Bend PD has a deputy chief. So different things, as you call it. But our organization is running well. We're looking at saving money. Tony came to one of our last command meetings, and I've never had a commissioner sit through, and that was nice. I hope it was enjoying you, because we talk about the hard issues. The other thing you asked is about the deflection program, and I'll be brief. September 1st will be a year that we've been in deflection. We believe it's running well. We have 28 people that have been through the 33 people been through the program. 28 people are in the program now. We've had a graduation about 4 months ago, and we have another graduation coming up with 9 individuals. We were funded again. The commissioners accepted our funding process all through grants. Although we say it's not local tax, it's taxes coming from the state, and they have guaranteed that they're going to run it. You would think that 28 is not a whole big, that's not a lot of people. Remember, we're only looking at police officers that are trying to divert people that have just a possession charge. Our DA has worked with us because many of them aren't diverted at the scene of the incident. Neil Marchington, who's an excellent program coordinator, latches onto them when they come to jail, because many of them will have other charges, and then he'll work with the DA, because the DA will drop charges on a whole bunch of different reasons, get those charges dropped, and then we can get the person in the program. The main benefit of this program really is, I still believe, social referral. Instead of a police officer having to cite you to get to this program, we're working with our Ideal Option and Best Care to say, do you need help? We have a place to help you. And before we'd send you to the hospital, or we just arrest you. Well, this can be your help. We're gonna keep you in jail you're gonna detox and go back out. Or what doesn't help you. So I value the program. The state values it. I think we're doing a pretty good job. We're doing as many as what Portland struggled, because I think they believe the number should be way higher. With, all that going through, they have about the same numbers we do in deflection. With the city of Portland being as big as it is, but we can talk more about it later.
Yeah. Lee, do you have any further questions?
No, I'm good. Thank you. I just was looking at how it's going. Thanks for the time, Mike. I appreciate the update.
You're welcome. MAT would be another thing. I'd give you an update next time as well.
Yeah,
Dedicated assistant.
Yeah, I think that would be great. I just want to be mindful of everybody's time right now. And I think we're gonna have some time in October to talk about some additional things, because we won't have the local plan quite yet, I don't think, until December, right?
We will, our draft October 1st, and then we don't know how long it'll take them.
For them to come back. Yeah.
So it's uncertain about the timing to come back to you with a more finalized draft.
Yeah. So I think that's kind of the plan for the fall. So in October, we have a couple of ideas for the agenda. If you guys, as always, if you have something that you want to add to the agenda, feel free to contact Lee and I, and we'll try to make some time for that. And then November, we'll have Holly, or I'm not, anyway, I won't bore you with the upcoming agendas, but we have some plans. And then I think probably in January, we'll start kind of getting back into the housekeeping of how we function as a board and try and make ourselves more effective and efficient, and have some collaborative opportunities with FAB, which is the Public Health Advisory Board. They call themselves FAB, apparently, so, okay, cool. They do a thing called Health Heroes every year, where they nominate somebody from public health and behavioral health. And so we may end up talking to them about that being a part of it. And I guess there is some history of some collaboration between FAB and BHAB. But over the last, I don't know, 5 or 6 years, I think things fizzled, but I think there's a lot of synergies that we can kind of take a look at. And they are having a retreat in November to they're getting 6 new members and new leadership also. And so Tom Kuhn is kind of their coordinator, which is, he's quite a bit more involved in running that than what we're used to here. And so I think Lee and I are going to go to the November retreat and just going to sit in and see how they do things and take some lessons from that. So
Maybe we can do a joint meeting someday.
that's kind of what's on our mind. We had asked to meet with the chair and the co-chair. In fact, I had emailed them, but they've had so much turnover themselves. They're bringing on 6 new members. And so Tom found out that we were looking to do that. He's like, why don't I meet with them? Just because they've got to get settled. They do something different with their membership. They have a designated seats on their board. And they made a decision about, okay, seat A should be somebody from St. Charles, and seat B from, so they have just designated things. That's different than what we do, because we have to have a certain percentage of people that have lived experience from the community. And we are not required, and they're not a statutory board, by the way. We are a statutory board. So there's some differences that we have to be mindful of. But anyway, I'm excited about the prospect of learning from them and collaborating. And that'll be some work that we'll kind of start digging into probably in January-ish. Yeah, really need to have you guys think about who would be good to join our board. And Cameron, you are in charge. So she's the point person. And I have Stephanie, I have you on the membership and onboarding committee too. Is that still okay with you to stay on that board and work with Cameron on that?
Yes, it is.
And I'm happy to help too. And so we will, on the community outreach committee, I don't want to try and find somebody to take over for Julie McFarling right now, because we may shake that committee up come January in the work that we do.
Do we know when she's leaving?
Their house is for sale. They're
So
gonna-
she's here until.
Yeah, and she didn't make it today because she's also on the board of the National Alliance for Mental Illness, and they're having a pretty big salsa dancing event tonight, so wish me well, because I'm gonna have to go to that.
Don't break anything.
Yeah. Anyway, all right, I'm going to adjourn the meeting. Thank you, everybody.
Yeah,
See you in
thank you.
October.
It's gonna be that.
Yeah.
How much?